Usually when we talk about a medical diagnosis, there's this expectation of absolute precision.
Right,
It
yeah.
feels like engineering, You break your arm, the X-ray shows that jagged white line on the screen, and the doctor just points at it and says, "There it is."
Yeah, and it's comforting because it's binary. I mean, the bone is broken or it isn't.
Exactly.
The problem is visible, it's easily categorized, and the solution is usually just a straight line from point A to point B.
But then you step into the world of prenatal neurodevelopment and fetal trauma, and suddenly that trusty X-ray machine is just useless.
Completely.
We're looking at a diagnostic landscape that is, well, honestly, it's murky. You're dealing with two patients at once, right?
Mhm.
Separated from the outside world, connected to each other in ways we are honestly still trying to fully map out.
It is the absolute definition of diagnostic muddy waters.
Yeah.
The variables are constantly shifting, and the stakes are impossibly high.
And that murkiness is exactly what we are navigating today. So for you listening, we are taking a stag of incredibly complex medical research and extracting a truly mind-bending story about human biology, survival, and microscopic architecture.
It's a fascinating topic.
It really is. Today, we are looking at a highly specialized 2026 systematic review and meta-analysis. It was published in the Acta Obstetricia et Gynecologica Scandinavica by lead author Marina Piergiani and an international team of experts.
Right, and they took on this really fascinating piece of literature looking at a very specific, very rare complication in twin pregnancies called TAPS.
TAPS.
Yeah, which stands for twin anemia polycythemia sequence.
So our goal for this deep dive is to understand what TIPS is, what happens when the worst-case scenario occurs inside the womb, and uncover the surprising, honestly, almost counterintuitive reason why surviving twins in this specific scenario completely defy the usual very grim medical odds.
Yeah, the mechanics of it are incredible.
And I promise you, even if you aren't an obstetrician, the mechanical cause and effect of this biological puzzle is going to provide a massive aha moment. Okay, let's unpack this.
Right. So to really grasp the gravity of what this 2026 study uncovered, we first need to establish the baseline of how these specific twin pregnancies work.
Okay.
The researchers are looking exclusively at MCDA twins, which stands for monochorionic diamniotic.
Okay, so if mono means one and di means two, I'm assuming this means they are identical twins who share a single placenta, but they have their own, separate amniotic sacs.
You've got it. Yeah, they are in their own individual rooms, but they are drawing from the same central utility system.
Got it.
And because they share that single placenta, their blood vessels physically connect to each other within that tissue. These connections are called anastomoses.
Anastomosia.
Right. And in a normal MCDA pregnancy, blood flows back and forth between the twins through these connecting vessels in a fairly balanced, continuous loop.
But sometimes that loop gets thrown out of sync, right?
Exactly.
And that's where TAPS comes into the picture.
Yes. TPS is a complication that affects roughly 3 to 16% of these shared placenta pregnancies.
Wow. Okay.
It can develop spontaneously, or it can happen after doctors perform laser surgery to correct a completely different twin complication. But what essentially happens is an unbalanced, agonizingly slow transfusion of red blood cells from one twin to the other.
Emphasizing the slow part of that transfusion, I imagine.
Very slow.
Huh.
It happens through a very small number of incredibly tiny placental blood vessels. Because the transfusion is so slow and constant, one twin, known as the donor, gradually loses red blood cells.
Oh, I see.
Over time, they become dangerously anemic.
So their blood basically becomes too thin. They don't have enough red blood cells to adequately carry oxygen to their developing organs.
Meanwhile, the other twin, the recipient, is on the receiving end of all those extra red blood cells.
Right.
As a result, they develop polycythemia, meaning their blood becomes abnormally thick and viscous. Their heart has to work incredibly hard just to pump this thick sludge through their system.
Okay, so imagine two houses sharing one main water line, but the plumbing is faulty.
Okay, yeah.
House A has a slow, constant leak draining their water pressure, while House B's pipes are practically bursting with thick sludge. That's essentially what's happening to these twins' blood.
That is a perfect analogy. And because this plumbing issue is hidden deep inside the womb, doctors have to find clever ways to spot it prenatally.
Because they can't just, draw blood.
Right. They can't just draw a vial of blood from a 20-week-old fetus to check their red blood cell count. Instead, they use Doppler ultrasound to measure the speed of the blood flowing through the fetal brain.
The brain.
Yeah, so typically they measure something called the middle cerebral artery peak systolic velocity, or MCAPSV.
Measuring brain blood velocity sounds incredibly technical, but if we go back to the house analogy, I suppose thin water moves through a pipe a lot faster than thick sludge.
It all comes down to fluid dynamics. If you have thin anemic blood like house A, it provides very little resistance. It moves much faster through the cerebral vessels. If you have thick, sludgy blood like house B, it moves much slower because of the high concentration of cells.
That makes total sense.
By measuring that specific velocity in the brain, obstetricians can diagnose TAPS and determine exactly which twin is the donor and which is the recipient before the babies are even born.
Okay, so we have established the plumbing problem. We have one twin with thin, fast-moving blood and one twin with thick, slow-moving blood, all connected by these shared vessels in the placenta.
Exactly.
But the study by Piergiani and her team zeroes in on a specific tragic event within this already complicated scenario. Like, what happens when one of those twins passes away in the womb?
Yeah, the clinical term for this is single intrauterine fetal death, or SIUFD.
Right.
To understand why the findings of this 2026 paper are so revolutionary, we have to look at the grim reality of what happens during a standard shared placenta pregnancy.
One without TAPS.
Right, one without TAPS, when one twin suffers an intrauterine death.
The baseline numbers for standard shared placenta twins in this scenario are incredibly sobering.
They really are. Previous systematic reviews have shown that in a standard MCDA pregnancy, if one twin passes away, the surviving co-twin faces a staggering 40% risk of also dying in the womb.
40%? Wow.
Furthermore, there's a 28% rate of neonatal death, which means dying within 28 days after birth.
Almost half of the survivors don't make it. What is the physical mechanism causing that mortality rate to be so incredibly high?
It all comes back to the shared plumbing. When one twin passes away, their heart stops pumping. Almost instantaneously, their blood pressure drops to zero.
Right.
But the surviving twin's heart is still pumping away and their blood pressure is still normal. Because their circulatory systems are intimately connected through those large placental vessels, that sudden drop to zero in the deceased twin creates a massive vacuum effect.
A vacuum effect that pulls the survivor's blood away from them.
It triggers an acute, massive reverse transfusion. The surviving twin literally bleeds out into the demised twin side of the placenta.
Oh my God.
Yeah, their blood rushes over to fill the empty zero-pressure void. This causes the survivor to experience severe acute hypotension, a catastrophic crash in blood pressure.
And when blood pressure crashes that severely, the organs are instantly starved of oxygen.
The most critical damage usually occurs in the fetal brain.
Okay.
It leads to profound cerebral ischemia, which is a lack of oxygenated blood flow to the brain tissues.
Right.
That ischemic event is what causes severe neurological damage, or, in 40% of these cases, death.
Wait, if the blood in our TAPS scenario was originally flowing to the polycythemic twin, why does one passing away suddenly reverse the flow and put the survivor at such extreme risk?
That's a great point.
Like, if house B is full of sludge, why does it suddenly drain?
This raises an important question, and it's one of fundamental physics. It actually doesn't matter which direction the slow leak was going before the demise.
Oh, really?
Yeah, blood, like any fluid, will always relentlessly follow the path of least resistance. It flows from an area of high pressure to an area of low pressure.
Nature abhors a vacuum.
Exactly. The moment the heart stops, the vascular resistance in that entire half of the circulatory system simply vanishes.
Wow, okay.
The surviving twin's pumping heart is pushing blood against normal bodily resistance, but suddenly one pathway offers zero resistance. So the blood just floods that way, utterly, regardless of the previous slow drip direction. That's a sudden, violent equalization of pressure.
So you have a 40% death rate in standard shared placenta pregnancies because of this massive flash flood reverse transfusion.
Right.
That is the baseline. That is what maternal fetal medicine specialists expect when they see a single fetal demise. But now, let's look at the 2026 meta-analysis by Piergiani.
Let's do it.
They looked at this exact tragic scenario, but only in pregnancies already complicated by TAPS.
They combed through the medical literature from the past 15 years and pulled data from 11 different studies, isolating 83 specific TCAPS pregnancies where one twin unfortunately passed away.
And just for context, in 89% of these specific TAPS cases, it was the donor twin, the anemic one, who passed away.
Yeah, the severe anemia and the resulting cardiovascular strain usually make the donor far more vulnerable to heart failure.
So the researchers are looking at these 83 cases, mathematically bracing for that devastating domino effect we just talked about.
Right. They are looking for that catastrophic drop in blood pressure.
But here's where it gets really interesting. You expect a devastating domino effect based on the baseline physics. You expect that 40% mortality rate.
Right.
But the survival rates in this specific cohort are completely upended.
The statistics they uncovered are truly remarkable. In these TPS pregnancies, the rate of co-twin death, meaning the survivor passing away after the initial demise, was incredibly low. It was just 4.9%.
Wait, from a 40% death rate down to 4.9%.
Yeah, and even more astounding, when they looked at neonatal death, the surviving twins dying in the first 4 weeks after birth, the rate was 0%.
0%.
Zero.
That is a staggering statistical difference. I mean, the baseline tells us this should be a catastrophic, highly lethal event for the surviving twin.
Absolutely.
But in TAPS, almost all of the surviving twins lived. You have a pregnancy already compromised by a complex disease, and yet when a secondary massive trauma occurs, the outcomes are vastly superior to a healthy pregnancy experiencing that same trauma.
That sounds impossible.
Yeah, why do the TAPS survivors have such dramatically lower mortality rates? What exactly is protecting them from that lethal vacuum effect?
The answer lies in the microscopic architecture of the placenta itself. It's about what we call the angioarchitecture.
Angioarchitecture.
Yeah, which is the specific structural layout and size of the blood vessels connecting the two circulatory systems.
We mentioned earlier that all shared placentas have connecting blood vessels, but a TAPS placenta must be structurally unique.
It is. Unlike a normal twin pregnancy, or even a pregnancy complicated by regular twin-to-twin transfusion syndrome, a TAPS placenta has a significantly lower number of these anastomoses.
Okay.
But more importantly, it's the physical size of the pipes. The connections in a TAPS placenta are almost unfathomably tiny.
How tiny are we talking?
We are talking about arteriovenous, arterioarterial, and veno-venous connections that are universally less than 1 millimeter in diameter.
Less than 1 millimeter. That is essentially the width of a pinhead.
Exactly. And what's fascinating here is that the structural flaw causing the disease is the exact same mechanism providing the profound protection.
Oh, wow.
Those tiny sub-millimeter vessels are the sole reason the initial transfusion of red blood cells was so incredibly slow, leading to the gradual anemia and polycythemia over weeks or months.
So what does this all mean for the listener? It means the plumbing is simply too narrow. When the pressure drops to zero because of the demise of one twin, instead of a massive, lethal flash flood of blood draining from the survivor, those tiny sub-millimeter pipes physically restrict the flow.
They do.
It's like trying to drain an Olympic swimming pool through a cocktail straw instead of a fire hose.
I love that image.
Right. The vacuum is there, the pressure difference is there, but the physical pathway acts as an absolute bottleneck.
The physical capacity of those vessels is simply too small to allow for the acute, massive hemorrhage that kills surviving twins in standard pregnancies. The fluid dynamics simply will not allow a lethal volume of blood to pass through a 1 millimeter opening fast enough to crash the survivor's system.
So the tiny vessels that cause the slow drip TAPS problem in the first place act as a built-in safety valve when tragedy strikes.
Yes.
The disease literally prevents the domino effect.
Because the vessels are so minute, the surviving twin doesn't experience that catastrophic immediate crash in blood pressure. They don't bleed out into the empty placental space.
That's incredible.
Their cardiovascular system is able to remain relatively stable and compensate, which is entirely why the mortality rate plummets from 40% to 4.9%.
It really is one of the most brilliant mechanical aha moments in biology. You understand the mechanism of the disease, and suddenly you understand the precise mechanism of the survival.
Right.
But if this microscopic bottleneck saves their life, are they completely out of the woods? I mean, does this mean they are born perfectly healthy?
We have to be very careful not to paint this as a total clinical victory.
Right, of course.
The mortality rate is low, meaning they survive. But the morbidity, the rate of severe illness and ongoing complications, is still incredibly high. The survival is a statistical miracle, but the clinical reality is still a high-wire act for both the parents and the medical team.
So what are the doctors actually dealing with after they realize the surviving twin isn't going to succumb to the immediate vacuum effect?
The most immediate pressing hurdle is extreme prematurity. The study found that preterm birth rates are incredibly high in these cases.
How early?
Over 80% of the surviving twins are born before 34 weeks of gestation. And 50%, half of them, are born before 28 weeks, which is pushing the limits of viability.
Why are they born so early if the cocktail straw protected them from the main trauma? Is the mother's body just like rejecting the pregnancy?
It's a combination of physiological triggers and medical interventions. When one twin passes away, the tissue in the deceased twin's side of the placenta begins to break down.
Oh, that makes sense.
Yeah, this can release inflammatory markers and change the chemical makeup of the amniotic fluid, which often triggers spontaneous premature labor. The mother's body recognizes the hostile environment.
And what about the medical interventions?
Other times, the early birth is iatrogenic, meaning the obstetricians actively choose to induce labor or perform an emergency C-section because leaving the surviving twin in that deteriorating environment is deemed far too risky.
And even though the cocktail straw prevents a massive lethal flash flood of blood, there are still minor pressure changes happening, right?
Yes, absolutely.
Like the pool is still slowly draining through the straw, so there is still a risk to the survivor's brain.
The bottleneck protects against a fatal hemorrhage, but it doesn't prevent all hemodynamic shifts. The survivor's blood pressure might not crash to zero, but it still dips.
And the brain needs stable pressure.
The fetal brain is exquisitely sensitive to even minor drops in oxygenation, particularly in the watershed areas of the brain where the blood vessels are smallest. The Perinatal study found that 10 to 15% of these surviving twins still showed cerebral anomalies.
Signs of brain damage despite the bottleneck.
These anomalies, like subtle ischemic damage or minor hemorrhages in the brain tissue, were detected either on highly specialized prenatal ultrasounds and fetal MRIs or on brain scans performed in the NICU after the baby was born.
And what about the blood itself? We started this whole thing talking about severe anemia and thick blood.
Right.
If the donor twin passes away, does the surviving recipient twin still have to deal with the sludge? Or vice versa?
They absolutely do. The underlying blood volume issue doesn't just vanish. In fact, the meta-analysis noted that 8% of the surviving twins ended up needing an intrauterine blood transfusion.
Wow.
Yeah. If the survivor was the original donor, they are still dangerously anemic. Or, if they bled just enough through the cocktail straw after the demise, they become newly anemic.
How do you even give a blood transfusion to a fetus?
It is an incredibly delicate procedure. Doctors use ultrasound guidance to insert a needle through the mother's abdomen, through the uterine wall, and directly into the tiny umbilical cord vein of the surviving fetus to deliver donor red blood cells.
That sounds terrifying.
They have to do this while the baby is still inside the womb just to keep it alive long enough to be born.
So, if we connect this to the bigger picture, this means doctors can't just sigh in relief when they see a TAPS survivor.
No, not at all. If we connect this to the bigger picture, the authors of the study insist that this data fundamentally changes how maternal-fetal medicine specialists must manage these pregnancies.
Because the risks are still so high.
Exactly. You can't just assume the baby is fine because they survived the initial event. The new standard of care must include immediate and highly detailed neurosonography to monitor the brain, as well as fetal MRIs to look for any signs of ischemic damage that the ultrasound might miss.
You have to monitor them constantly to see if they need that high-wire blood transfusion, and you have to prepare the parents for a very premature delivery in a specialized NICU.
Precisely.
The low mortality rate buys you time, but it demands extreme vigilance. Now, as comprehensive as this 2026 meta-analysis is, Piergiani and her team are very transparent about one massive limitation in their research.
It's a limitation that is unfortunately common in retrospective obstetrical research, a severe lack of long-term data.
Right. Because we know these babies survive birth at incredible rates. We know the mechanics of why they survive. We know they spend weeks or months in the NICU. But what happens after they go home?
We don't have a clear answer from this specific data set. None of the 11 studies included in this meta-analysis tracked the long-term neurocognitive development of these children as they grew up.
None of them.
No. We don't know how that 10 to 15% rate of cerebral anomalies translates into the real world. Does it mean subtle learning disabilities at age 5, motor function issues at age 10, cognitive delays in high school?
Which is deeply frustrating because the very first question parents are going to ask when they are sitting in that clinic is, will my child be okay long term?
Of course.
And right now, the data from this specific cohort just isn't there to give a definitive answer.
The researchers do point to one older, separate study that looked at TAPS survivors generally, not necessarily those who experienced the tragic loss of a co-twin, but just children who survived TAPS in general.
And what did that show?
That older study noted a 30% risk of neurodevelopmental impairment as those children grew up.
30%. That's nearly a third of the kids facing some form of long-term impairment.
And interestingly, that older study found the impairment was much more common in the donor twins, the ones who suffered from the chronic severe anemia, compared to the recipient twins who dealt with the thick blood. But again, how those specific numbers map onto the unique cohort of twins who survived a single intrauterine demise is currently unknown. It highlights a massive, urgent need for pediatricians and neurologists to track these children for years, not just weeks.
It really emphasizes that birth isn't the finish line, it's just the end of the first chapter.
Exactly.
We've solved the mechanical mystery of the immediate survival, but the long-term developmental trajectory is still a major question mark.
It's a reminder that human biology is rarely simple, but it is deeply logical if you look closely enough at the microscopic mechanics.
It really is. So to everyone listening, think about the sheer paradox of human biology we explored today. The precise microscopic flaw that creates a life-threatening complication for these twins, those tiny, less than 1 millimeter faulty pipes, is the exact same architectural quirk that saves the survivor's life when tragedy strikes.
It's amazing.
It makes you wonder, how many other assumed defects or diseases in human biology might actually be hidden defense mechanisms just waiting for the exact right context to prove their worth? Thank you for joining us on this deep dive.